Crap. Do you want me to, oh, there you go, it's worked. Okay. So yeah, so I'm doing the limping child, but it's basically just pediatric kind of hip things because I wanted to include a condition that isn't really a limping child, but is quite relevant. So we're going to start with this case. I'll just read it out. So it's a 3-year-old boy who's seen an A&E because he's crying. His mum says he's had a limp for the last few days. He hasn't got a fever and he otherwise feels well. And on physical examination, slight movement of his hip is tolerated, but excess motion causes him to cry. So apart from kind of like normal peds history that you would ask, can anyone think of like some questions specifically for this presentation that you might want to know about the child? You can just put it in the chat. Actually, I'll just leave the case on the thing and then you can see it. Recent illness, yeah, that's really good. Or even like, yeah, so just kind of what would you ask about a history if they're in pain and any hip problems, dislocation at birth? Yeah, really good. Trauma, yeah, that's really good. Actually, didn't put that on the slide, but that's a really good point. Yeah. Yeah. Family history, yeah, exactly. Yeah, so that's really good. And what kind of investigations are you going to want to do on him? Hip exam, x-ray, yeah. And kind of more basic, before we jump to like imaging and things, what are you going to do? So yeah, you do an exam. What kind of like going from medical investigations, what would you do before imaging? Yeah, bloods. Yeah, exactly. So really the most important thing here is markers of infection in the blood. So basically you guys got that all. So I've put just like pertinent things, but trauma is a really good point. I should add that to the slide. The main thing you want to kind of know about with a child that's coming with hip pain or a limp, have their risk factors. So has there been a recent illness? How quick was the onset? So like, did he just seem to be, he like wake up and seem to suddenly be in pain, or has it slowly been getting worse over a couple of months? Then just like classically, is it a red hot joint, which you could get from examination? You can also ask the mum. Family history, you guys said, newborn problems. Newborn hip problems is a really good point as well. So then in terms of investigations, basically you are wanting to do like just basic things to see if they're systemically unwell. So you're going to do obviously their basic obs, like you would in A&E anyway. And then things like full blood cancer, like you're looking for raised white cells, you know, all of that, raised ESR, CRP, etc. So basically you ask all of that, and then the mum says that he had an upper respiratory tract infection 2 weeks ago. There's no family history or kind of birth history of note, and joint is not red or hot when you examine it. And his OBS are within normal ranges. So not got an elevated white cell count, not got an elevated ESR or CRP, and this is his hip X-ray. So can anyone tell me about this X-ray? Don't have to present it, but just like anything you've noticed, or what do you think about the X-ray? Anyone? Okay, so yeah, exactly. So this is basically a completely normal pelvic X-ray. There's nothing wrong here. So can anyone tell me what the probable diagnosis is for this child? Does anyone have any idea? So they're systemically well, they've had a recent illness, and they got a painful joint. Okay, so this is transient synovitis of the hip. So it's basically like irritable hip is what they call it. It's self-limiting and it's just inflammation of the hip. They don't really know why, but the typical age range is about 2 to 10 years old. And they can basically, they have like mild to moderate hip pain. Sometimes they can weight bear, but it's just like they're limping still. The blood markers are completely normal usually, but sometimes they do have a fever, but it won't be very high. And essentially just the main thing to remember with this is that it's supportive treatment, and it will just resolve by itself. There's kind of no long-term like damage to the joint. So, hey, I'm just teaching. Sorry, okay. So I'm teaching, yeah. Sorry. So yeah, basically it's self-limiting, it's supportive, and you basically, they just love this in SBAs because it's like, it's comparable to like septic arthritis, which is one that they're going to try and trick you out on. So I'm just going to quickly put a little note in on it, because you guys have done it in ortho last year, but it's important in the context of peds because it's obviously the thing you want to rule out first. So can someone just chuck in some symptoms you're going to get with septic arthritis? Anything at all? Any examination findings? Red hot joint, exactly. Fever, yeah, they're systemically unwell, yeah, exactly. Does anyone remember what the most common organism is? Yeah, raised CRP, yeah. Yeah, it's Staph aureus. Yeah, well done. And what do we do to investigate? Aspirate the joint, exactly. And what are we sending it for? Yeah, MCNS, exactly. So microscopy cultures and sensitivities from the joint aspirate, exactly. And it will kind of be like turbid maybe, and yellow, and it'll have high white cells within the actual aspirate itself. So exactly what you said, and they'll have a raised white cell count, all their inflammatory markers will be up basically. So does anyone know what the criteria that we use is to find out, is blood cultures? Yeah, you wouldn't just go straight in with blood cultures probably, but unless they are systemically like really unwell and they're septic, exactly. You're going to start with just aspirating and taking basic bloods, basically. And then obviously if it spreads into their bloodstream, then you will want to do blood cultures. So does anyone know what criteria we can use to help determine whether it's to predict like the probability that a child has septic arthritis or anyone has septic arthritis? It's like a criteria. I actually hadn't heard of it until 5th year, but I think they use it on everyone. Yes, you can. Go on, Tina, you can give it away. Koshas, exactly. So Koshas criteria, this is it basically, and it's 4 things. So it's are they non-weight bearing on the affected side? Is their ESR over 40? Do they have a fever? And are their white blood cells over 12 basically? And essentially the important thing to remember is basically 3 or 4 out of 4 means that almost certainly have septic arthritis. And I know in our exam this year they chucked in a lot of conditions that were really similar, and you had to like really know the condition quite well to be able to differentiate it. And I think Kosher criteria is just something to definitely learn, even if you think, because sometimes they can make it not that obvious, and people think septic arthritis is going to be really obvious in a STEM, and it isn't, like past med sometimes. So I would actually learn this criteria, and because like I said, like they can have a fever with transient synovitis. So yeah, I think this is probably the most useful thing to remember to be able to differentiate septic arthritis from something else. But that's basically that. So does anyone have any questions on septic arthritis or irritable hip so far? If not, I'm going to just go on to the next case. So a concerned mum brings her 6-year-old boy to A&E. She said he's had progressively worse hip pain over the last 5 weeks, and she's noticed that he's now limping. So some hip x-rays, pelvic x-rays ordered. Oh, is anything on the screen right now? No. Okay. So this is what they show. Can anyone tell me what anything at all? You don't have to present it properly, but can anyone see any abnormalities in that? Yeah. Femoral head seam, exactly, yeah. Well done. That is exactly it. Bilaterally, yeah. So both hip joints, the acetabulum are both they're both deformed basically. And so specifically, so you're right, it is Perthes. And specifically the part of the bone that gets affected is the epiphysis. And I thought I just put this diagram in because I never really I always forget about the structure of bones. I think it's actually quite useful to just remember with Perthes, that's the epiphysis is a bit that's getting damaged. The metaphysis is the bit that has a growth plate in. I just think it's useful to know that because you will come across that when you're looking at it. So as you guys said, it is Perthes, which is avascular necrosis of the femoral head. And it's usually children aged around 4 to 8. And it basically happens, they don't know exactly why, but there's impaired blood flow to the femoral head. And it basically becomes deformed, essentially. So does anyone know what gender it's more common in? Can't see. Males, yeah, exactly. It's 5 times more common in boys. So this can be differentiated from transient synovitis because it's much more gradual. So transient synovitis usually only lasts around 2 weeks, and even if they have a similar kind of pain that they're complaining of, it won't continue for however long. This was 5 weeks, to be longer than that. And also it's important to remember that the pain might not necessarily just be in the hip, so they can get pain referred to their groin, to their bum, to their knees. Yeah, and it worsens with activities. And oh yeah, that's a good thing. That's a good mnemonic to remember it by. Perthes is primary. So yeah, basically in any SBA stem and just real life, if the pain is persisting for over 4 weeks, you should be considering Perthes, and they're systemically well as well. So in terms of investigation, so obviously I've just shown they've done a hip x-ray. Does anyone know what investigation you might do if the hip x-ray is normal but the child is still complaining of hip pain, they still got a limp? What other type of scan we can do? So you can do MRI, yeah. There's a specific type of scan though that you can also do. Yeah, a bone scan, exactly. It's they get injected with radio-labeled dye, technetium, whatever that chemical is, and basically it just captures activity in the bone. So it's you do a hip x-ray first, and if you can't see any destruction, you either do MRI or you do a bone scan, basically. And does anyone know what kind of classification is used to classify Perthes sometimes? The name of it. Oh, I just clicked on category, exactly, yeah. So this is on PassMed. I've never seen it actually come up ever. I don't know how much you need to know it because the management you need to know Perthes is quite basic, but I guess it's good to just be aware that is basically a staging system they use. So they basically, it's histological features are used in this to stage it. So stage 1 is basically stage 2 onwards essentially has sclerosis, so thickening of the bone, and there's no cystic changes, and it gets worse and worse. And the femoral head, the structural integrity is stage 3, and there's only 4 stages, so you can learn it if you want. I just don't know if it's that relevant. I didn't really learn what each one was, but just be aware that that's a staging system they use. So does anyone know how we manage Perthes? Cast, yeah, so you can, but what if it's yeah, exactly. So what I'm getting at basically is that the younger they are, you essentially just observe if they're under 6 years old and see if it gets better itself, because they actually have worse outcomes if you operate when they're like 5, and it actually can resolve itself sometimes. But essentially, I guess the reasoning is if they're older and it's not resolved alone, then they need surgical intervention for it to resolve. And yeah, basically, the more of the femoral head that's involved, the worse the prognosis is for them later. So obviously I've put arthritis there, but does anyone know any other complications that can happen from Perthes for them when they're like later in life? So increased fracture risk. Yeah, so they will probably have an increased fracture risk secondary to the fact that they get osteoarthritis. Exactly, they do get osteoarthritis as well. And they can actually sometimes have a limb length inequality, because if you think like the femoral head is literally eroded when it's really severe. And just generally they can get like stiffness later in life, even after surgery, and just general reduced range of movement of that hip. So that's basically it for Perthes. A lot of it you don't need to know a huge amount of detail, but you kind of, the most you need to know is so that you can differentiate it in an SBA essentially. So it's these like the hip ones I think are a bit sneaky because it's like paediatric GI disorders. You kind of like, you think there's not too much to it, but actually it can be a bit harder in SBA to differentiate. So that's why I'm like telling you the things that are more specific to each condition, because I think that's actually what helps you out in a question. Does anyone have questions about Perthes or anything before I go on to the last bit? Okay, so I'm just going to go on to the next one. So a mother presents to her GP with a 5-week-old baby. She's noticed over the last few weeks that the baby's left leg appears shorter than her right, and there seems to be an extra deep crease on the inside of her left thigh. She's otherwise systemically well, and there were no issues with her development so far, and the mother's delivery and pregnancy was uncomplicated. So given what you might think the diagnosis is, does anyone know what screening test the GP could do quite easily to figure out if this is the case? A bit of a two-step. It's not really, not an SBA, but given what you think the likely thing is, what would you do? Barlow and Ortolani. Yeah, exactly. Well done. So what is the diagnosis here? Yep, exactly. So can anyone remember which way around Barlow and Ortolani are, like what each one does? Barlow breaks, yeah. So Barlow dislocates an articulated femoral head, and then Ortolani is the other one. Yeah, Ortolani puts it back in, exactly. So this is just a useful thing. You do actually need to know, yeah, I saw this mnemonic, which was like RAB and DAD, like adduction to dislocate, abduction to reduce for Ortolani. It's useful to know that because, like, you know, I went through the NIPE a couple of weeks ago, and this is part of the NIPE. And so if you are asked to do it, you should definitely have an understanding of like which way you're moving the legs and which maneuver it corresponds to, and then like what you're trying to do when you're doing it, if that makes sense. So it is actually worth learning that. But exactly, so that's a screening test. So this is DDH, developmental dysplasia of the hip, or congenital dislocation of the hip. So that's basically, it's actually kind of like a spectrum of conditions. So you can kind of have the femoral head not completely developed, or you can have subluxation, so not completely, or you can just have the hip completely dislocated. So there's like a bit of a spectrum of what it is. And does anyone know like the typical risk factors for DDH? Which I would like learn. I think it's worth learning. Breach, yeah. Female, family history, yeah. First child, yeah. Anyone know any other ones? Okay, so that's really good. I think some of you might have the all the F's mnemonic down, because basically it's the way I learned it was like all the F's. So female, firstborn, foot first, family history, further bony abnormalities. So like clubfoot, for example, puts them at increased risk of having DDH, and oligohydramnios, so reduced amniotic fluid in the mother's placenta, and then increased birth weight, basically. And I actually would learn like the oligohydramnios one, because I think people, obviously it's easier to learn all the rest of them, but these ones are like, I feel like SBAs like can try and trick you out with it either being poly or oligo. So I've learned that basically. And that's just kind of like rote learning, to be honest. So does anyone know what kind of imaging we do for if we suspect this, and management as well? Actually, let's just start with imaging, unless people have already typed it. Ultrasound. Yeah, so ultrasound is one option. Does anyone know what that depends on, whether you do that or not? So that is right, but you don't do that for everyone. So basically, it just depends on age. So essentially, sorry, I keep picking out of it. Yeah, so if the patient is younger, it's easier to pick it up on ultrasound. That's fine. So I hope it didn't all come up. So basically, if they're over 4.5 months, you do a pelvic X-ray because it's more sensitive, and if they're under 4.5 months, you do an ultrasound. That's just like something to learn. And does anyone know what this cute baby is in? So this is a management for some of them. Pavlik harness, exactly. Yeah, well done. So I remember it as flabs, so the way that they keep their legs, they're flexed and abducted. So basically the important point is that most of these problems will actually stabilize by the time they're 6 weeks. And does anyone know what we do at 6 weeks for all children? So kind of connected to the NIPE. So we do the newborn, like the baby check at 6 weeks. So we do the NIPE one, and then we do the 6-week check. And that's basically, you have to do Barlow's and Ortolanis again at the 6-week check, because most of them should have stabilized by then. So if they've not, you're going to have to like image it and probably do some management. So essentially, again, the management, like the imaging, depends on the age. So if they're less than like 4 to 5 months, they normally put them in a Pavlik harness. And if they're older, then they can benefit from surgery. So I've just said that you do it at the 6-week check. Does anyone know? So that's the Barlow and Ortolani, you do it at the NIPE, and you do it at 6 weeks. The GP can just literally do that. But does anyone know when you would do an ultrasound scan for a baby? There are some criteria which you need to know for screening for DDH. Okay, for some reason it's not coming up on the slide, which is really annoying, but it is actually on my PowerPoint. So basically, everyone gets the Barlow and Ortolani test at the NIPE within 72 hours, and then again at 6 weeks, like probably at their GP. But for any child, regardless of whether they've got, like, you're suspecting that they have it, there's basically 3 that you need to know where they do just have an ultrasound. So not just the screening test, they also have an ultrasound. So basically, if there's a family history, first-degree family history, so like if the mum or dad had hip problems in early life, even if they're now fine, like if when they were younger they had it, they need an ultrasound. And then any multiple pregnancies, so twins, triplets, both the children or however many children need ultrasounds. And also basically if they're breech presentation at 36 weeks onwards, so even if they're breech at 36 and then they kind of turn around again, they're cephalic when they're born, you still need to ultrasound them if they had been breached at 36 weeks. So like a tricky SBA stem could trick you out by saying that they were like cephalic, but you know, they did a external cephalic version where they turned the baby and they were delivered normally. You still need to do an ultrasound because at 36 weeks of a breech, basically, and that increases their risk still of having DDH, even if they were turned subsequently. I'm really sorry that's not come off the slide. I don't know why that's not there, but it is on the actual PowerPoint in the Teams file. So I would remember that. So it's just 3 things for the ultrasound: first degree relative, having family history, having problems when they're younger, breech presentation, and multiple pregnancy, basically. And then just remember that everyone gets Barlow and Ortolani's. So yeah, that was a bit of a whistle-stop tour. There are other ones like Sufi and stuff, which came up in ortho last year, but that is like the most classical presentation. I thought it wouldn't be worth it. Like the obese teenager who has a limp. I mean, it's worth learning, but like the presentation is so classic. So does anyone have any questions about any of that? If not, I'll hand over to Tina. No? Okay, cool. That's everything. These aren't all the hip problems, by the way. These are the ones that I just touched on because you should definitely know about them, basically, and can sometimes be hard to differentiate. Okay, I'm going to stop sharing. Yeah, nice.
Thanks very much, Dhivya, and thanks for letting me answer all of the questions. It was nice to remember one thing. One thing I wanted to say is that there is, just to kind of try and link Dhivya's and my presentations, there's an articulate rise course somewhere buried on Moodle that is like a lot of like histopathology of like paediatric tumors. I kind of did it in a panic just before my exam. It would, if you've got time, do it like when you're not in such a panic, and you might like retain a bit more than what I did. I couldn't find the link or anything, but it is somewhere on Moodle. Cool. All right. So I'm going to do focus on oncology, and the idea is it's going to be on like first presentations that might not relate so much to like the original or like the primary cancer. A lot of what we're talking about, or sessions that I've getting in 6th year at the moment, is on like clinical reasoning. So what you like the kind of demographics of the patient, like how that kind of predisposes you with a certain like picture in your mind. So that would be like how abdominal pain in a 3-year-old, a 53-year-old, or 83-year-old will make you think of different things. And how like a presenting complaint might like relate, like you might pick something up just by like being savvy of like different signs and doing like a thorough systems review. With oncology, learning red flags for your 2-week wakes is really important. I'm not going through it in this presentation, but we'll probably do it like maybe closer towards the exam, or like do a crossover with GP and things. And another thing is like performance status, which just gives an idea of like how aggressively you're going to treat someone, or if they're kind of shifting towards like a palliative care setting. So I've got a mini case just to begin with. 66-year-old who presents to GP with a painful right arm, and with like numbness and tingling, and it's like weakness you notice as well. But then you spot this in his eyes. So what do you think? What does anyone get an idea of what that is, or what could be going on to link those two things? Yeah, very good. Horners, very good. So what could link a painful arm and a presentation of Horners? Very good. Well done. Yes, so this very clever GP ordered a chest x-ray and saw that, and with a CT saw that. So it was invading the brachial plexus, and that was what was giving his symptoms that he noticed, but he hadn't actually noticed the Horner syndrome himself. So well done for that. So this is a slide that I made for myself last year. It is quite busy. Oh, actually, I didn't have the cat last year. I included that for you guys. Because turns out cats and dogs can get Horners too. But basically, there's different, depending on where the lesion is, you will have different like symptoms of Horners. And the key one is the areas of anhidrosis. So this is like a little bit niche, but it did come up once last year, and I made this slide, so maybe it's useful for you guys. I think the key thing to remember, like, is it central, is it preganglionic, is it postganglionic? If it's central, then you'll get anhidrosis of quite a large area. If it's preganglionic, only the face, and postganglionic, no anhidrosis at all. Don't worry if this is too niche for you or anything like that. I made it in a panic last year before exams and thought I'd include it. But the yeah, you can see the cause. You can come back to this in your own time, but it's just, and it kind of stands to reason if you like look at the diagram and like where the causes of the lesions could be. So does anyone know any other examples of where we might see compression or obstruction in like that has like an oncological basis that we might where a tumor is compressing or obstructing something and a patient might present spinal cord compression? Excellent. That's a good one. We'll definitely come to that later. So the ones I came up with, yes, SVCO, excellent. Who knows what's going on here? Oh yeah, I didn't get that one. Well done, Sylvia. And does anyone know like the law that? Yes, very good. Has anyone? Yes, well done. Okay, so what does someone? Can someone state that for me? Courvoisier's principle. I accept any spelling. You'd recognise it in SBA. But yeah, it's so painless jaundice and a palpable gallbladder is unlikely to be due to gallstones. Fantastic, well done. Very good. So, and this one, someone guessed it already. Does anyone know the sign that this patient is eliciting? When you ask, I mean, you definitely shouldn't do it if someone is presenting with SVCO. Yeah, Pemberton sign, excellent. And so this is sometimes an emergency. Quite often it presents like subacutely. So you do have to like manage it, but it's not like a massive emergency. Does anyone have any idea how you would manage SVCO? Do people know what I mean by SVCO? Yeah, steroids, good. Yeah, stenting and steroids, very good. And then treating the underlying cancers, of course. Great. Okay, and then someone guessed this one already, spinal cord compression. So these are just some of the symptoms that you can have. So we'll just move on, and that one is an emergency if you're suspecting that. And anyone with back pain, you always want to screen, especially if they're older and have like risk factors of cancer, screen for that. So we'll talk about spinal mets. I've given you one. So these can have different effects. So one can give you pathological fractures, which might not necessarily result in spinal cord compression, but can give you back pain. You can have compression really at any level, but the one that people always like are really concerned about is called Acute syndrome. Does anyone know the management of this? It's one of the things similar to SVCO. Yes, Dex, does anyone have any idea about the dosage? Full spine MRI, great. Yeah, 16 milligrams of Dex, or you can say 8 milligrams BD. And you can throw in some PPI as well if you want to give them some gastric protection. Excellent. Okay, so this actually was, well, we had someone with back pain in our OSCE in one of our 5-minute stations was on this. So you had to take a history. I can't remember if we had to go through this whole, I don't think we had to do like a proper ATE, but these would be the main points. So you can talk about full spinal precautions. So like getting someone, like on bed rest, not moving until they've got clearance from the neurosurgical team after having had their full spine MRI. If they're in urine retention, you would catheterize them. If they're in pain, you would give them pain relief, which I did not offer in my OSCE and felt very silly after. And it's important if you're thinking about cauda equina to do a PR, testing for saddle anesthesia and anal tone. Further management is an MDT approach. It's beyond us. These are some red flags. I'm not going to read them all out, but it's definitely worth learning for history taking for exams. We'll talk a little bit about metastases. So really common sites are the brain, the lungs, the liver, and it's worth knowing which cancers spread where. So does anyone know which are the commonest cancers that spread to the brain? Yeah, very good. Yeah. So I remember as, this is my little acronym, like mnemonic, you don't have to, like, so lucky bright kids calculate maths. So lungs, breast, kidneys, colon, and melanoma. And does anyone know bones? Does anyone have a way of remembering which cancers metastasize to bone? It's just important to know these because, like, kind of Mets are in both the brain and the bones are just, yeah, much more common than primary cancers. Yeah, BLTKP. Yeah, that, well, so I remember it as lead kettle, so PBKTL, but it's exactly the same as your one. Other people do pair midline organs. The lung is, like, lots of cancers spread to the lung, liver. If you think about like venous drainage, so like kind of like hematogenous spread, like a lot of abdominal and perineal organs will metastasize to the liver. Sometimes you come across questions that ask about most likely routes of metastases, but this is it's quite difficult to find information on. I tried to make a slide for you guys, but that's just definitely worth knowing those bits. So we've kind of talked about direct compression and invasion. Other neoplastic syndromes that we'll come across, you can group them by like endocrinopathies, neurological, mucocutaneous, so like on the skin, heme. Oh, skipped ahead there. Oh, I didn't animate all of this. I've sort of given it away, but who knows what this is? Or what the way of remembering the symptoms of this one is. They all rhyme with each other. Yes, bones, stones, moans, groans, and psychiatric overtones is the other one. But it can also be asymptomatic if it's kind of borderline high. So yeah, thrones is good. Well done. So this can be an emergency, especially if it's like above, if your calcium's above 3.5. Does anyone know what to do to treat this in an emergency? Say someone comes in, yeah, lots and lots of fluids. That's great. Yeah, good, good. Bisphosphonates, excellent. Well done. So that's the main thing. Don't get caught out. I think in the past they sometimes suggested using like loop diuretics, which is just like, it's not a good idea because then you're giving them fluids and you're giving them a diuretic. It's not proven to have like any more of an effect. The only time you would give a loop diuretic is that you've given them so much fluids that you fluid overloaded them, and then you need to diurese them. So yes, it's aggressive IV fluid. Just take care, renal impairment and heart failure. IV bisphosphonates, as you guys have said. And then second line, you can use calcitonin if bisphosphonates aren't doing the trick. Denosumab and dialysis. But those would be like decisions from your seniors. And then just remember what bloods that you want to do. You want to do the like bone profile, PTH, Usinese, and just regularly check their calcium. Okay, so another short case. So someone, a woman in her 60s, presents with low mood, weight gain, easy bruising, and a chronic cough. Got some pictures there of before and after treatment. Who knows what this is? What syndrome this is? Yes, well done. Well done. That's another example, but we can make him go away. So Cushing syndrome versus disease. Who knows which one is which? Yeah, good. Well done. So I guess you guys all clocked that it was Cushing's. So I'm not going to go through the features of Cushing's, but yes, there are different types. Pituitary will be Cushing's disease, and adrenal and lung will be the other sources. So in lung cancer, small cell lung cancer is associated with ectopic ACTH secretion. You'll do, as you guys have anticipated, like dexamethasone suppression tests, measuring plasma and urinary cortisol to detect suppression from the baseline. So those would be the results that you would expect. So you would expect a pituitary tumor to respond to high dose suppression, dexamethasone, and be suppressed. Is that okay? Did anyone have a question there? Or sorry, someone came on my screen. But yeah, just feel free to chat out if you'd rather talk than type. Okay, how about this one? It's another paraneoplastic syndrome. So this man gets very, very flushed and feels very hot and warm and has diarrhea for about 4 hours whenever he eats food. I've tried to take these from real cases, so like case reports from the BMJ. Yes, well done. Well done. Well picked up, guys. That's great. Yes, so this is carcinoid syndrome. So the major features will be flushing, and if it's really, really severe, then they can actually pass out from the low blood pressure. I get cramps, diarrhea. I can get quite a deep edematous. Oddly enough, I'm not sure about the pathophysiology, but they can also get right-sided valvular disease. Apparently, it becomes like very fibrosed. But anyway, so it's a feature of the neuroendocrine tumors. Commonly gastric, which is when like you get the kind of postprandial effects, and you can treat it with like somatostatin analogs, like just for the symptomatic relief until you treat underlying cancer. So how about this one? Sorry, I thought I animated all the pictures. Ignore the pictures for now, but the short case, what are you thinking with this one? Yeah, very good. So these are some of the two, like myasthenic syndrome. What's the other myasthenic syndrome that you can get? Less commonly with cancer, but it's basically the only other myasthenic syndrome that we ever really hear about. Yeah, great. Very good. Oh, you guys are all on fire. So yes, the two ones. So Lambert-Eaton myasthenic syndrome is slightly more associated with cancers than myasthenia gravis. Do you know which cancer Lambert-Eaton syndrome is sometimes associated with? Yes. And how about myasthenia gravis? Yeah, excellent. Okay, so I'll just click through these ones because you guys seem to know all of this. Right. Okay. I hope this is useful for you guys, by the way. You seem to all be like very on top of it and like spotting everything. I'm really impressed. So we'll go through some full blood count profiles. So if you came across an elderly gentleman that's in his 80s, was tired all the time, did a full blood count, showed iron deficiency anemia, what would you think, or what would that be a red flag for? Yes. And do you know which? Yeah. Okay. Yeah. Colorectal cancer. That's a 2-week wait for. Oh, I don't know if it's a flexible sigmoidoscopy or colonoscopy. Yeah. Well done. Yeah. Just those criteria are definitely worth learning for GP. How about this one? A lifelong smoker with an incidental finding of increased platelets. mean, you can kind of guess it from the lifelong smoker bit, but it is one of the 2-week wait for lung cancer. Good. I mean, that's quite easy. Very, very high white blood cell count. What do you want to know with that? If you want, why is there increased platelets in lung cancer? I'm not sure. I'll look that up. It's definitely been explained to me once, but I don't want to give you a bad answer. Actually, no, I'll do it after the talk, so I'm not typing whilst you guys are listening. So if there's a high white blood cell count, you want to get differential, and you want to start thinking like, is this going? If it's an older patient, if it's something like CML, CLL, if it's in a younger patient, so like if you had a 3-year-old boy who had abdominal pain, you could feel hepatosplenomegaly, they had a bit of a fever, that is actually a real emergency. You want to get them straight to hospital to be assessed the same day by a paediatrician because you're worried about AL. So anemia plus a high ESR, what could you be thinking then? I'll just flick through. Oh, okay, so that one could be, yes, myeloma, not melanoma. Yeah, very good. Well picked up, guys. And don't worry, it's really easy to do. If someone had a very high hemoglobin and hematocrit, what could that be? Yes, excellent. Yeah, so you can see the just going to change. So that is polycythemia there. You can see a patient's arm compared to a normal arm. Oh, interesting. Thanks, Dhivya. And who about? What about this profile? What do you think that is? Someone has decreased platelets, increased D-dimer, decreased fibrinogen. Yeah, DIC. Well done. And that's what DIC can look like. Someone can be like bleeding and clotting all at the same time. It's a bit of a disaster. Does anyone know what this is? It's quite a niche sign, I'll admit. It's a bit difficult to tell from the photo. So it's a migratory thrombophlebitis. Do you know the name? He shares the name with the test that you do for hypocalcemia, where you like tap on, you do the blood pressure cuff. Yes, Trousseau's, well done. And that's can be a sign of adenocarcinoma or pancreas. Yeah, Trousseau's, well done. Well done. So adenocarcinoma, the pancreas, stomach, or lung. Okay. So Trousseau actually got gastric cancer and had this sign. Do you mean the Canadian president, or do you mean the guy? Or is it the same guy, Trousseau, for the calcium and the cancer? I love medical fun facts. Oh, that's quite sad. At least it's authentic. Yeah, so I've got another emergency. We're running slightly short of time. But I'll flick through this one quickly. So it's a heme-related one, hemolysis syndrome. A typical case would be someone who is like shortly after they've had chemo for a like highly active cancer. So it's basically the tumours, is kind of a lot of cancer cells are lying after the cancer, and all of the intracellular contents is going to the blood. So the kind of blood profile you'd expect would be increased uric acid, increased potassium, increased phosphate, decreased calcium. The calcium decreases because it's mopping up all the phosphate, and they'll probably present with an AKI. Does anyone know how we treat this? Yeah, hydration. Yeah. Raspberry case, excellent. Great. And what if they had hyperkalemia and some ECG changes? You guys all know the drill for this one, I'm sure. Yeah, I knew it. All fine. So that's just to remind you that some of the different ECG changes you might see. Yeah, excellent. Yeah, I'm not going to go through the whole hyperkalemia one because I'm sure you guys are on it. Cool. So I think, yeah, I'll skip the next slide because that was just, the next one is just on derm things. It's more like a kind of spot diagnosis, or like kind of, maybe we can go through it. Okay, someone has lots of creases on their palms, like they've just come out of a bath, but it's like constant and they're quite thick, quite velvety, you might say. Does anyone know what that's a sign for? Or does anyone know what tripe is? It's basically like the lining of like the stomach of like different animals, and some people, I don't know if they still eat it, but some people do eat it. So you can call it like tripe palms or velvet palms. Yeah, for gastric cancer. Excellent. How about these? Do people know what this is? You might recognize the photo because I think it's like the stock photo that's used like in everything. Yes, excellent. So we have heliotropic rash, Schulstein, Gottschalk's papules. So this is actually, people with this, if they're presenting for the first time, you have to take it quite seriously because there's quite a high incidence of cancer with these patients. They are usually followed up for about 5 years after presenting, because that can be like, it can be like, and it's lots of different kinds of cancer: ovarian, lung, pancreatic, gastric, colorectal. How about this one? Does anyone know what this is? I can tell you it's a triad of clubbing, painful arthropathy, and periosteoitis. If we didn't X-ray, so you've got clubbing, but there is. It's a bit mean. Yeah, it is clubbing. Yes, exactly. HPOA. And what's it associated with? Which cancers? Brilliant. Small. So apparently it's more non-small cell lung cancer and pleural mesothelioma. But I take your point that clubbing is a sign for small cell lung cancer. Cool. And what else have I got here? Does anyone know what this is? So yes, Paget's disease of the nipple. So you can get lots of not melanoma. Sorry, it's not. I guess the photos aren't that clear. Yeah, Paget's disease of the nipple. It's eczema around the nipple, and it's a sign of like cancerous tissue behind the nipple. You can get a lot of other rashes around the breast. It can be like in the midline, can be under the creases, but if it's around the nipple, you really want to take that seriously. And how about this? What do people think about this? Yes, and what cancer can it? gastric or like GI adenocarcinoma. Well done. Okay, so that was quite a good like spot diagnosis quiz. You guys are really clued up on all of that, which is excellent. So it's come to 7 o'clock. I think maybe what we should do is post like the feedback form. I did have one more slide going through an ATE assessment, but I think maybe we'll leave that for another day, because you've had an hour and it's been like quite intense. Should we do that? So we post the feedback and let you guys go at 7, because I know.
Yeah, I'm just trying to find it. One sec.
Okay, cool. Do you guys want to go through more ATEs, and how would you guys like to do it? Would you